Good afternoon, good evening, wherever you might be tuning in from today. Welcome to We See Hope's very first Facebook Live. My name is Erica Crespo. I'm the social media director for We See Hope. And with me today is Dr. Andrew Stacey, Associate Professor of Ophthalmology at the UW Medicine Department of Ophthalmology, and Dr. Debarshi Mustafi, Assistant Professor of Ophthalmology, also at UW Medicine. Both Dr. Stacey and Dr. Debarshi are surgeons at Seattle Children's Hospital. Helping me facilitate today's discussion is Melissa Mills, a We See Hope board member, bilateral RB survivor, and a genetic counselor at Stanford Children's Hospital. Today, we're going to be talking about a fascinating research breakthrough in retinoblastoma that you may have heard of lately as we've been talking about it on our social media. Our guests, Dr. Mustafi and Dr. Stacey, have developed a simple blood test that can determine whether an RB1 gene mutation in a child arose from the chromosome copy that is inherited from either the mother or father. So why does this matter? Well, their research found that retinoblastoma behaves differently depending on which parent's DNA copy carried the mutation. If the mutation occurred on the copy of the gene inherited from the father, the cancer is often more aggressive, making early intervention even more critical. So this discovery could help doctors make more informed treatment decisions, catching the disease earlier, and even guiding lifelong cancer surveillance for survivors. And the best part is that this new test delivers results in just 24 hours compared to the months-long waiting list for traditional genetic testing. Before I hand it off to Melissa to dive into our interview portion, I want to let you all know that we will be holding a Q&A at the end of this interview. So if you have questions at any point, please just drop them in the comments of this video. If you're using a screen reader, you'll comment just as you would on any Facebook post or video. If you have to leave early, if you have to sign off early, that's okay. We are going to have this recording available here on Facebook and on our YouTube, so you can watch it at any time you'd like. And please ask your questions, even if you have to leave early, because you might still be able to get them answered during the Q&A so you can watch later. Please know we cannot address specific questions about specific care treatment plans as they relate to individual cases. So I'm going to be in the background monitoring the chat, and I'll hop back in for live Q&A at the end. Melissa, take it away.
All right. Well, as a genetic counselor, I always want to start out with just a little bit of grounding with some of the basic genetics of retinoblastoma. Just to remind folks, here's a little picture of chromosomes. So we have 23 pairs of chromosomes. We get half from our mom and half from our dad. And the 13th chromosome right there, that's where the gene for retinoblastoma, the RB1 gene, is found. We get one copy from our mom and one copy from our dad. And the RB1 gene is a tumor suppressor gene. So we really want to have two working copies of that gene protecting us from cancer. And when folks have retinoblastoma in both their eyes, bilateral retinoblastoma, some folks have inherited that from a family member, but most of us bilateral folks, we're what they call de novo, which means new. So we are the first ones in our family to have that. And so it wasn't something that was given to us by our mom or dad. And I think that's important to note in this conversation, because we're going to be talking about, we found a retinoblastoma mutation. Was it on the chromosome that came from mom or the chromosome that came from dad? And we always talk in genetic counseling and prenatal genetics about the fact that whenever you have a pregnancy, there's a 3 to 4% chance of something new happening. You could have a different birthmark. You could have a chromosome problem like Down syndrome. You could have a mutation in the retinoblastoma gene and end up with a new heritable retinoblastoma. And so I think it's really important to kind of think about that genetics before we talk more about this exciting ability to know, which chromosome did it happen by chance? There's nothing anybody did or didn't do, eat or drink, things like that could have caused it to be on the chromosome from mom or be on the chromosome from dad. So that was just really quick background, and I'm happy to answer any more general genetics questions if folks have those. But I want to make sure we have time to get in to spend time with Dr. Mustafi and Dr. Stacey, who we are so grateful that they could be here today to talk more about their research, how this has implications for folks, and how survivors like myself and others, we might be able to support the research in the future. So I'm gonna jump into the questions if we're ready. All right. So first, to both of you, what is the current genetic testing method for diagnosing retinoblastoma, and what is different about your proposed test or the test that you've had in the literature now?
Thanks. I'll start with that. Thanks, Melissa, for that overview. And it is important to understand the background of it. As a genetic disease, genetic testing plays a really important role in retinoblastoma. When a new child comes in with retinoblastoma, if it is unilateral in one eye, we don't know if it's something that's affecting the whole body. If it's bilateral, then we can assume that it's something that affects the whole body, but we don't have evidence of it yet. What genetic testing does is it helps us know what the risk is to the patient's other eye if they only have the tumor in one eye. It also helps us know what the risk is to the rest of the body, because if the retinoblastoma gene is affected in every cell of the body, then the whole body has some risks associated with it at that point and in the future. So what we traditionally do as soon as we diagnose a patient with retinoblastoma is we start the process of obtaining genetic information and genetic testing. What that usually looks like is a vial of blood, which is sent to some sort of processing location. However, it's not so simple because the testing is expensive. And so before we can do anything, we normally have to get approval from insurance. And that takes some time because unfortunately this disease is rare and many insurance companies don't move quickly with rare things. And so we have to fight some battles to get them to approve the genetic testing. And then when we get the genetic testing, there's a number of tests that have to be done. Traditional genetic testing is done by taking the whole string of DNA and chopping it up into these small little pieces. And when you chop it up into small little pieces, you can kind of stitch them back together and try to figure out where a problem lies inside of the gene. And for us, it's the RB1 gene. That process of chopping up and stitching back together and trying to find a location where there's a problem, that can take a very long time. So the truth is, traditionally, and what most places are still utilizing, genetic testing for a patient with retinoblastoma takes anywhere from 3 to 4 weeks, if it's very fast, up to more like 3 to 4 months. And that is very precious time, because when I don't know the status of somebody's genetic test, I actually have to treat them differently. If a patient has retinoblastoma through the whole body, what we refer to as germline retinoblastoma, then I have to screen them and I have to screen their siblings as well. And until I know that they do or do not have germline retinoblastoma, then I have to continue that screening. I also don't know what the risk is to the other eye. A lot of variables are up in the air until we can get this test back. And actually this whole research that we're going to be talking about today, all of the discoveries and breakthroughs we've had, kind of stems from this problem. So Debarshi and I work together at the Seattle Children's Hospital, and he works on some pediatric retina problems that are related but a little bit different than retinoblastoma. But he runs a very interesting lab that he'll tell you about that does some testing that can help in this situation. And so we were sitting in the operating room one day, and I was lamenting to Debarshi how long this genetic testing was taking, and we really wanted to fix the problem. And so he kind of came to me and he said, you know what, we might have a solution to this problem, something that might help speed it up. And so what is different about our process is it moves a little bit faster. And I guess I'll let Debarshi talk a little bit about why it can move a little faster.
Yeah, thanks, Andrew. I think the biggest takeaway from, I think the first question is sometimes we don't know, we don't have solutions to answers right away. And it does take people in different fields to think about things. So I'm not a retinoblastoma clinician. I'm a pediatric retina specialist, but I've had the pleasure of training and now working with Andrew. And sometimes we recognize we can fix a problem that applies to a different field, in this case, retinoblastoma. So I'll just take a little bit with what Andrew was saying, is that what traditional genetic testing does is it takes this DNA that they take from your blood, the child's blood, and they break it up into pieces and kind of put it back together. And I like to use the analogy of trying to do a 500-piece puzzle. It's very hard. A lot of pieces look similar. If you lose a piece, you may not be able to put the other pieces together. It's very hard. What we do and what's unique about our technology is that we are not chopping up DNA. We are extracting DNA directly from blood, much smaller amounts of blood, and we are sequencing that native long pieces of DNA. So now when we try to put RB1 gene together and understand what's going on, instead of doing a 5,000-piece puzzle, it's a 5-piece puzzle. So it is something a child could quickly put together. So we make less mistakes when we put the DNA back together to align it to that gene. And because we don't do any modification, so we don't chop up the DNA, we don't do anything to process that DNA, we just take the DNA directly from the blood cells, we can look at secondary modifications. So what does that mean? So when we think about retinoblastoma causing disease, we think about mutations. So these are changes itself to the code of the DNA. So our DNA has 4 letters, A, T, G, and C. If one of those is accidentally changed during development or passed on, that's when you get a mutation. But what's interesting is there are other changes that happen to our DNA. And one of them is called a modification. So the letter, the A, T, G, or C is kept the same, but there's a modification made on top of that letter. And that signal is what we were able to exploit to actually identify if a mutation that a child has arose from the maternal or paternal copy of the RB1 gene. So we were able to connect 2 big dots. 1, the mutation itself, and 2, this secondary modification. And although there are methods to do this with traditional clinical sequencing, it is very complicated and very hard to do because they look at such small pieces of DNA. So because we had very large pieces of DNA, we were able to take advantage of that and really come to this conclusion. And that's going to kind of detail the rest of this kind of story that that we'd love to share with everybody here.
Great, thank you so much. And so our next question, which I think segues quite nicely, does this parent of origin knowledge that now with the new technology that we can get, does that knowledge change our understanding of the biology of retinoblastoma?
Yeah, I'll start with this one. It really does. And the biggest thing that we have been able to identify is that there's more to just knowing if a child or an adult or anyone with retinoblastoma simply has a mutation. And this may be something that families have experienced where a parent may have a mutation and they pass on retinoblastoma to a child because it is inheritable, and their child has either a better or worse course of disease, meaning they're better able to accept treatment, their eye is more salvageable, or they don't get secondary cancers while the parent may or may not have. And what we used to think is, oh, this is all due to how we treated them or when we caught them. But it could be that even though 2 people have the same mutation RB1, they actually have 2 very different diseases. Because if your mutation is on one copy, let's say the copy you got from dad, it can act very differently than if the mutation is on the second copy, which is if it came from mom. And knowing which copy it came from, as Andrew will talk about later, actually dictates what your clinical prognosis may be and how you might respond to chemotherapy. And we think, and the last part is kind of just a thought, we haven't proven this yet, we think knowing this not only dictates your your burden of primary pediatric ocular cancer, but potentially the secondary malignancies you could get because of having germline mutations.
I agree. I don't have anything to add to that.
Okay. And I think this is kind of wrapped up in all this, the next question that we had, which was talking more about the parent of origin and inheritance. So is this, and I think this is important to be clear on. So does the parent of origin indicate inheritance, or does it identify which parent's copy of the mutation was passed on?
It's a really great question, and thanks for starting it in your intro. But Debarshi could probably answer this one well.
Yeah, so I think Melissa did a great job of explaining this in the intro, is that in cases, so, when we talk about germline or heritable cancer, that means that everyone has a kind of a mutation in every cell in their body. And that can arise from two reasons. Reason one is that if a child has it, it could be because it was inherited from a family member. So for those we call familial retinoblastoma, but those only account for 10% of patients that have germline mutations. So 90% of patients, when they have a germline mutation, it is the first mutation in that family. So you look at mom, you look at dad, and they don't have disease and they don't have that mutation. So when we talk about parent of origin, and we use this term because it was used in the literature, and Andrew and I and many other retinoblastoma providers have talked about that this is not the perfect term, but it's a term that we use for now, and we'll probably modify it. But it doesn't tell us that a person gave you retinoblastoma. It is the copy that happens to have the mutation on it. And as Melissa pointed out, to be very clear, this mutation is not given to us. So if we say that the mutation is on the maternal or paternal copy, it does not mean that the father or mother did something to pass that mutation on. As Melissa pointed out, every new generation gets about 3 to 4% new changes. And when we look at it from a genetics standpoint, that means that there are about 100 new mutations in our genes in every person. So, I have 100 new mutations than my parents. My kids have 100 more mutations than I did, and they're all different. And they could happen, one of them could just by chance happen to be in the retinoblastoma gene, and it could actually cause disease. So there are a lot of factors involved in this, and all we are able to tell you is that this happens to fall on the copy that was given by a certain parent. We cannot, it doesn't say that this happened because of X, Y, or Z, or even at what stage of development, but we can say that because we can use this modification signal and the mutation, we're able to assign parent of origin in the child. So we can say, hey, you have RB1, you have a mutation in exon 13. That mutation happens to be on the same chromosomal copy that we think you inherited from your mother or father. And as Andrew will talk about, knowing that will dictate how your disease might progress. But it does not change, it doesn't tell us anything about the parents. And even if parents have kids again, it doesn't mean that they will get that mutation because one child got it.
Thank you so much. And anything to add, Dr. Stacey? Are you good? Okay.
No, I think I'm good.
Actually, and that does segue kind of to the next question. These are all flowing nicely. So the next question was about parent of origin influencing treatment. So I guess kind of coming back to what you saw in your research about the differences in the disease with the differences on which chromosome the mutation was found, and then how that might impact treatment. You kind of touched on it a little bit. I don't know if you want to touch on that a little bit again.
Yeah. So it's important to note that we are still in the early stages of the research here. And though we've published our results and they're good publications, we've really only looked at results from our center in the Pacific Northwest. And so we need to proceed with some larger studies, which we are doing, to make sure we know exactly what we're seeing. But in general, it's pretty clear that the location of the mutation on which allele it's on does alter what is happening. And it alters what is happening in a few ways. In the first way, it tends to change the presentation or how early a patient comes to see the doctor. So when a mutation is on the paternal allele or part of the chromosome, we have seen that these patients actually present with larger tumors and later clinical stages than when the tumor presents or when the tumor is on the maternal allele. We've also seen that the tumors from eyes with mutations on the paternal or father's allele tend to be a little bit harder to take care of. They don't respond as well to chemotherapy and other treatments, and we tend to not be able to save them as easily as eyes that have mutations on the maternal allele. So how does that change treatment? Well, it remains to be seen exactly how it will change treatment, but there are a few ways where we as the treating physicians are taking this into consideration. To know that a tumor is a little more aggressive may lead you in one of two directions. Perhaps it leads you to wanting to be much more aggressive up front with your treatment, knowing that if you have a chance of saving the eye, that you might need to be a little bit more aggressive. It may also affect your decision to remove an eye. If you have a very advanced eye where you're kind of on the fence about whether removing the eye is the right decision, if you know that it's a more aggressive type and the chance of us being able to save it with lots of chemotherapy is low, that might lead you and the family to say, well, it might be easier in this situation just to remove the eye up front rather than to put the child through all of these treatments, which may not work in this situation. So it's going to be an important variable moving forward, though how exactly it's used is a bit up in the air at the moment.
And then actually, and kind of piggybacking on that and going back to you, Dr. Mustafi. So we have like the information that we found about the parent of origin influence, but we also have your new faster test. And and is that something and that actually is more translatable right now, potentially, to improve diagnosis and treatment? Could you comment a little bit about that?
Yeah, so all of the testing that we've done to do parent of origin is on this kind of more rapid long read sequencing method that we've been using in our lab. Current clinical systems do not use that, so we are in the process of kind of making this available in a clinical environment. Mm-hmm. That being said, we are able to accept samples for research testing. So everyone that we've enrolled so far from Seattle Children's has been through a IRB approved study. We have now expanded this because we made a few observations from Andrew's adult patients that maybe parent of origin plays a role in their secondary cancer. So, Andrew seeing both pediatric and adult provider gives us access to these adult patients, these survivors who we can recruit from. We don't have a timeline of when this will be in the clinic, let's say, for a test to be ordered. But in the meantime, we are very fortunate to offer research testing to interested families to better understand that. We still have to work through all the details of that, but we do want to kind of make clear to the families out there that, even though we may not be able to offer this as a clinical readout at this time, we are working with foundations to make this a research test available to families as we move this towards clinical testing. The one thing I'll talk about is that the cost. So the cost of traditional testing can be thousands of dollars. And that's because every test is kind of tiered. So first you check for a mutation, then you check for something else, then you check for the modifications, and it's usually not done in all one test. I would say the real hallmark of this discovery is that we can do all of those things in one test. And that really eliminates the tiered testing, which makes it rapid, and it takes the cost out of the equation. We're doing things probably at a quarter of the cost of a traditional clinical test. And most of our sequencing, I think I might have one in my office. So most of our sequencing is done on this chip. So this is the size of the chip. Fits in my hand. That's how small it is. So every patient's DNA that we isolate, we sequence on this chip. It connects to a USB device to a computer. But the size of that also makes it available to endemic areas where retinoblastoma is most problematic. We are very fortunate in the US, and Andrew knows the real numbers, but the survival rates are above 90-95%, right? But in certain continents, that's not true. And part of that is genetic testing. So you can imagine if we can take this small chip and test in areas, this could make a real impact there too. So I know that's a little out of the scope for this talk, but there are a lot of things besides the rapidity. It's also the cost effectiveness and the mobility nature of this technology that I think will take us to the next step.
Excellent. Thank you so much. And yes, hopefully we can broaden it beyond where we currently are. And then are there any other long-term implications for survivors? You mentioned that it may have some impacts on aggressiveness for secondary cancers, things like that. Is that going to be part of future research? And what are your thoughts on that right now?
Yeah, I'll talk about that. So remains to be seen, but the biology certainly points to this being a very important variable moving forward. We know that every patient who has germline retinoblastoma is at high risk or higher risk than the population, the general population, of having additional tumors throughout the body. And that's simply because the RB1 gene, the retinoblastoma gene, does not only control the cells in the eye. In fact, the RB protein, the RB gene, is a very important modifier and protein for every cell of the body. And it's a tumor suppressor in every cell of the body. So if it's not working right, then every cell of the body has an increased risk of developing cancer. So these germline patients in the future have a significant risk of second tumors, as many on this call probably are aware themselves. So we do believe that this is going to have an important role in being able to predict the timing and aggressiveness of second tumors. This is a place where we are actively recruiting. It's something where if you were interested, we would love to get some information from you if you're an adult survivor. And I don't know that in any time in the near future we're going to have clinical results for you where we can actually give you information to help you and your local doctors make decisions, but you could help future patients or yourself years in the future to understand a little bit better how this works. So definitely there are long-term implications for survivors knowing what your allele or parent of origin is for your RB1 mutation.
I think that's great to note that we are still in the early stages of understanding, but as a member of rare disease, unfortunately, retinoblastoma kind of qualifies as that, as a sort of a rare, very specific subtype of cancer. I think I know that the survivor community is going to be really interested in helping out and finding out more. It's kind of a collaboration in these smaller patient groups. So we'll make sure with We See Hope and other avenues to make sure we can make those connections and see if we can get folks involved in your research, because I think this is really exciting and important going forward. I think we checked and we don't have anything live. Feel free to chime in if anyone has any questions on the Facebook Live. Two more things I'm thinking of. One is that there were some questions when we kind of first put this out there about, okay, so I inherited retinoblastoma from my mom, but now maybe I'm a male, and if I go to have children, does it stay as a mom allele, or basically the being on the maternally inherited chromosome, or does that switch because now I'm a male and I'm going to be passing it on to my children? And so I was wondering if that's what you, I wonder if you could comment on that from what you found in your research, which we know is preliminary, but very interesting.
Debarshi, you want to take that one?
Yeah, so it does switch. So if you, let's say, as a male inherited it from your mother's copy, you have two copies, and your copy that you have it on is the maternal copy. However, when you now pass on your copies to your child, you basically have a 50-50 chance of passing on the normal copy or the copy that had the RB1 mutation, both of which will end up being the paternal or father's copy. So if you do end up passing on that mutation, even though it originated from your mom, it's going to, in that child, be a paternal or father's copy. And we actually have seen this in families. So, and the best way for us to understand that is in cases where we know the family history. So we know a father passed it on to her daughter, and then the daughter passed it on to the to their child. So we see a paternal copy switch to a maternal copy, basically, when we look at these generations. And it has been very consistent. And our first kind of test was to test it in people that we knew had a family history. And then we did it on these newer de novo patients. And I don't know if, Andrew, you want to add anything on there?
The one thing I'll add is when you're listening to researchers like Dr. Mustafi and I talk about these things, what I don't want you to think is that the differences we're talking about are absolute differences. These are relative differences. And so just because a person is a male doesn't mean, or let's say a child has a maternally derived mutation or a paternally derived mutation. We'll say just because a child has a paternally derived mutation does not mean that chemotherapy won't work and we will lose the eye. And just because a child has a maternally derived mutation does not mean that it's going to be really easy to treat and they're going to see really well. So the differences are not absolute. They are significantly different, but there are relative differences between them. So still you're going to get eyes that are easy to treat that come from a paternal allele. And still you're going to lose eyes that come from a maternal allele. And still patients, survivors who have a maternally derived mutation will have second tumors. It's just that they're different. They're not exactly the same mutation. So that's the only thing I would add is don't think of these things as absolute differences. They're just relative differences.
That is super helpful. Thank you. Oh, sorry, Dr. Mustafi.
Oh, I was going to say the same thing. I think we're talking about probabilities, so nothing is absolute. So, we see a difference, but that doesn't mean that difference is 0 to 1. There's an area in between that we're kind of putting a probability on. And I think a lot of things that we are doing is we're testing the blood, which is giving us an idea of that first germline mutation. Keep in mind, in order for cancer to occur in the eye, there needs to be a second cancerous mutation in the eye, which we are not testing for. And that could also dictate treatment response and things like that. So, this is a very good prognostic test of how things may go, but there are many other factors involved. So even though this could give us an idea, like Dr. Stacey is saying, it's not a complete answer, and it doesn't put you into a, yes, this will be easy to treat. No, it won't be.
Great. And so also I was thinking now, like, what are you excited about for next steps, maybe with retinoblastoma or even beyond retinoblastoma?
I can start there, and then maybe Debarshi can talk about things beyond retinoblastoma. But I want to mention one question you had, Melissa, is how, I think you were maybe alluding to this, how the rapidity of the test can affect things. The rapidity of the test from a clinical standpoint will absolutely affect things. We'll be able to make decisions quicker when new patients come in. That is something that's going to take a long time to roll out. There's going to need to be approvals and tests available, and it's going to be a while. But when that happens, I think it's going to be very important. I'm also really excited about the potential of this being something that is available to lower income countries, like Dr. Mustafi mentioned. It is far more affordable and far more portable than any kind of genetic testing we have available right now. And that plays into a lot of our highest needs in the retinoblastoma world and things that we work on a lot in our research. And so anybody who's helping and supporting this research is helping and supporting future genetic testing in low-income countries as well.
We all have to work together in these small groups of patients to help everyone across the world in the end. That's wonderful. Thank you.
Do you have any?
Yeah.
Do you have any thoughts about?
Yeah, I think the one thing that I think Dr. Stacey and I are really working on next is trying to explain this difference. So we see this prognostic difference, this potential treatment difference based on what allele your mutation may be on. The question that both of us have wondered is why that's the case. Why is one copy worse off or better off when it has the same mutation? So one thing that we're trying to figure out is kind of the basic biology of when that gene is mutated, what is actually happening to that protein that's being produced. Because our thought is if we can understand that, imagine a world where if you do have a mutation and we can't necessarily maybe negate that mutation, but we can somehow, by changing the modification signal, swap it from a paternal to a maternal to lower your overall risk of primary and secondary cancer. That would, be a great way to slow disease and things like that, but it'll help. We'll need to understand the biology behind that. So that's kind of our nitty-gritty next step. But I think the bigger thing that we're all trying to do is recruit more patients. The effect we saw was very big, even though it was a small cohort, which to me means that when we see this in a larger cohort, we're still going to see a very important signal. But we want to do that by recruiting patients from other big centers, from survivors from across the country, around the world, and really kind of make this the test that we go to when a child is born with presumed retinoblastoma.
Well, thank you everyone for your time today. This has been extremely informational and educational. Everyone who's watching, thank you for tuning in and listening and learning with us. Like I said, this will live as a recording on the page. I saw some comments of people fiercely taking notes. This will be a recording, and if you do have questions, feel free to come back to this video and ask them. Dr. Stacey and Dr. Mustafi, we are so grateful for your time and generosity in sharing this groundbreaking research. And we really do deeply appreciate the work you're doing for the retinoblastoma community. Everyone who's watching, thank you for joining us. Please know your support makes conversations like this possible, along with our in-person events, like our upcoming RB Family Day in San Francisco. You can look that up in our events and our Facebook page if you'd like to attend. And of course, all the free resources we offer on our website for family and caregivers. Please consider donating so we can continue serving the RB community in this manner. You can donate on our website. You can donate at the link I have above this video. We appreciate all the support. Thank you, everyone. Thank you, Melissa, for your contribution today. And Dr. Andrew, Dr. Debarshi, hope to speak to you soon. Appreciate your time.
Thank you.
Thank you.
Bye, everyone.